Have you ever wondered why some physical injuries from childbirth stay hidden for years, um, only to surface as major health issues way later in life?
Yeah, it's a huge issue, and it's something that just isn't talked about enough.
Welcome to the deep dive. Today, we are taking your stack of medical studies, clinical trials, and longitudinal research spanning over a decade,
hmm
and we are unpacking a highly specific, very crucial medical mystery. Namely, can forceps delivery cause hidden muscle injury?
It is a phenomenal question based on the sources you've sent. I mean, it touches on a diagnostic blind spot that affects millions of women worldwide.
Right, because usually when you look at a medical diagnosis, there's this expectation of precision, right? Like if you break your arm.
X-ray shows the break.
Exactly. The x-ray shows that jagged white line, the doctor points to it, and that's that. The protocol is clear.
Right.
But when you step into the world of childbirth and pelvic trauma, that x-ray machine is, well, it's essentially broken.
Yeah, you are looking at a diagnostic landscape that is incredibly murky.
Okay, let's unpack this, because I am genuinely amazed here.
hmm
Childbirth is, one of the most fundamental human experiences, yet your sources reveal this massive knowledge gap regarding the actual physical trauma involved.
It really is wild.
How are we still in the dark
Uh-huh.
about the unseen mechanics of the pelvic floor? I mean, how does that happen?
Well, the answer lies in the sheer mechanical forces at play, which are, frankly, incredibly difficult to quantify in the actual moment of delivery.
Right.
Combine that with the structural complexity of the female pelvis, and it's a perfect storm. So if you want to understand why certain tools might cause an invisible injury.
You have to look at the foundation taking the brunt of those forces first.
Exactly. And the core structure highlighted across all your research is the levator ani muscle.
Okay, the lamb.
Right, the lamb. The sources focus heavily on that. And from a structural standpoint, this muscle forms something called the levator hiatus,
Yes.
which the literature describes as the largest potential hernial portal in the human body.
Which sounds terrifying, but it just means it's an opening where internal structures could potentially fall through if the support fails. Right.
Exactly, which is a brilliant piece of biological engineering when it's intact and working properly.
Sure.
But that same levator hiatus is also the critical soft tissue barrier that a baby must pass through during a vaginal delivery.
Right, so it's doing double duty.
Mm-hmm. And to understand the trauma, you really have to look at the biomechanics of that passage. Because during the crowning of a fetal head, this specific muscle, the lamb, it has to stretch by a factor of 3.2.
Wait, hold on. You're telling me a muscle is designed to stretch over 3 times its normal size naturally?
Yes. Literally 3.2 times its original length.
How does any muscle survive that without tearing? I mean, if I stretch my bicep 3 times its length, my arm is literally falling off.
Totally. Any normal skeletal muscle would just snap.
Mm-hmm.
But the human body prepares for this through pregnancy hormones, particularly one called relaxin.
Oh, right, relaxin.
Yeah, and relaxin fundamentally alters the collagen matrix in the pelvic floor. It turns a normally rigid skeletal muscle into something incredibly elastic, but just for a brief window of time.
That's amazing.
It is. But here's the catch. Even with those elastic fibers working perfectly, you are pushing the absolute limits of human anatomy.
I mean, 3.2 is just a massive number.
It's a degree of distension that would completely rupture any other skeletal muscle in the human body.
Wow.
So because the lamb is pushed so far to the edge of its mechanical tolerance naturally, it becomes highly, highly susceptible to any extra physical intervention.
Which brings us to the core injury defined in your sources, which is lamb avulsion.
Mm-hmm.
And based on the clinical definitions here, this isn't just a stretch or a little, micro tear from pushing.
Not at all. An avulsion is a macro trauma.
Meaning it's big.
Yeah, it means the pelvic floor muscle is literally torn off its insertion point on the pubic bone. It completely detaches from the skeletal structure.
That sounds incredibly painful.
To be specific, the research often refers to a pubococcygeus avulsion, which is the main central belly of that levator ani muscle, just tearing away from the bone.
Okay, so if you think of the pelvic floor as a supportive hammock for all your internal organs, your bladder, your uterus.
Right.
An avulsion means the thick ropes holding that hammock have actually snapped off the hooks on the wall.
That is a perfect analogy. It works as a hammock, yes, but unlike a static hammock, it's also a dynamic gateway.
Right, it has to move and contract.
Exactly. So when those ropes snap, you don't just lose passive support, you compromise the entire structural integrity and the active contractile strength of the pelvis.
Wow.
And the baseline statistics on how often those ropes snap are honestly sobering.
Yeah, let's get into the numbers because they blew my mind.
The studies show that about 21% of women sustain this kind of avulsion during their first vaginal delivery naturally.
Just naturally.
Yeah, and across the various cohorts you shared, that range fluctuates anywhere from 13 to 36%.
Up to a third of women in some studies, just from the natural biological process. That is staggering.
It really is. And keep in mind, that is the baseline.
Right.
We just established that naturally the muscle is stretched to its absolute breaking point. So the critical question your sources tackle next is, well, what happens to that overstretched hammock when you introduce rigid metal instruments to pull the baby out?
Right. And here's where it gets really interesting, because the research draws a massive, stark distinction between the two main tools used in assisted deliveries.
Forceps and the vacuum extractor.
Exactly. And they are not treated equally in the data at all.
No, from a pure physics perspective, the difference is profound. Let's look at the forceps first.
Okay.
Forceps are essentially two large metal blades. And to use them, the doctor has to insert these blades into the birth canal, wedging them intimately between the maternal tissue and the baby's head.
Which means you are adding significant physical volume to the birth canal.
Exactly. You are taking a space that is already stretched by a factor of 3.2, a space holding on by its absolute elastic limits, and you are shoving rigid, unyielding mass into it.
It's just wild to picture that.
The physical thickness of those blades adds centimeters to a circumference that simply has no more stretch left to give.
And the vacuum is different?
Completely different. The vacuum extractor, known clinically as a ventus, operates with a totally different mechanical profile. The vacuum cup is applied solely to the top of the baby's head.
Okay, so it's like trying to pull a tightly stuck cork out of a wine bottle.
Okay, I like that.
The vacuum is a suction cup placed right on top of the cork. But forceps are like wedging two metal crowbars down the sides of the cork before you pull.
Yes.
Of course, the neck of the bottle takes drastically more damage with the crowbars.
That is exactly it. And extending that physics analogy, the forceps don't just act as crowbars adding volume, they also alter the traction.
How so?
Forceps provide a massive mechanical advantage to the human operator. The pull forces exerted during a forceps delivery can be twice as high as those recorded in a vacuum delivery.
Wait, really? Double the force?
Yeah. Double. You have more physical volume stretching the tissue outward and double the directional force pulling against it.
Oh, wow. And the longitudinal data absolutely backs up how destructive that combination is. Looking at the 10-year follow-up study you provided, the one comparing women who had forceps to those who had vacuum deliveries.
The 10-year data is really telling.
Yeah, a full decade after the birth, the prevalence of a levator avulsion is nearly tripled after forceps.
The numbers are incredibly stark. 49% of the women who had forceps deliveries showed clear evidence of a levator avulsion a decade later.
Almost half.
Yeah. Compare that to only 18% of the vacuum deliveries. Nearly half of the forceps group had the main pelvic muscle completely torn off the bone.
It's hard to even process that.
Yeah.
But the sources also introduce an important nuance here.
Right.
Like, all forceps use isn't universally catastrophic. Or rather, the severity of the damage is heavily influenced by the specific technique of the operator.
Yes, technique matters immensely.
Because there's a whole section in the sources detailing something called the ANEF technique.
Right, the anterior non-episiotomy forceps technique. And what's fascinating here is that this biomechanical detail proves the injury isn't just an inevitable side effect of the tool.
Human mechanics matter.
Exactly. One hospital in your sources implemented this ANEF technique and dropped their rate of severe obstetric anal sphincter injuries, or OASIS, from 8.9% down to just 1.9%.
That is a massive drop. But how does changing the technique actually save the muscle if the volume of the metal blades is still exactly the same?
By altering the vector of force and preserving the surrounding architecture.
Okay, what does that mean in plain English?
So the ANEF technique explicitly avoids routine episiotomies, which are surgical cuts to the perineum. An episiotomy actually compromises the structural integrity of the surrounding tissue ring.
Right, you're making a cut in a taut rubber band, basically.
Precisely. So by keeping that tissue intact, and by training doctors to change the exact angle at which they apply traction, the ANEF technique redirects the mechanical pulling force.
It directs it away from the vulnerable insertion point of the lamb on the pubic bone.
Exactly.
What's fascinating here is how the global medical community is interpreting this exact volume and force data. because forceps take up so much physical space and increase the avulsion risk so dramatically. Some countries in Europe have almost entirely abandoned forceps.
Yeah, they've shifted heavily in favor of the vacuum extractor.
They've looked at the mechanics and recognized forceps use as a highly modifiable risk factor for permanent pelvic floor damage.
They are actively changing the standard of care based on these physics, which is huge.
Okay, but this brings up a massive clinical contradiction that just seems baffling to me.
What's that?
Well, if forceps are causing a major muscle to detach from the bone in nearly half of the women who undergo the procedure, why aren't doctors diagnosing and treating it immediately in the delivery room?
Oh,
Like, if an athlete tears a hamstring, they know it instantly, the doctor can physically feel the defect, and the treatment protocol starts immediately.
right.
So why can't an obstetrician just feel a detached pelvic floor?
Right.
Why do you need high-frequency ultrasound wands just to diagnose a torn muscle?
It feels totally counterintuitive, I know, but in the medical literature, this is classified as an occult injury.
Occult meaning hidden.
Exactly. It is completely hidden from traditional diagnostic methods. Going back to your hamstring analogy,
Yeah.
if you tear a hamstring, the surrounding tissue is relatively normal, so the structural defect, the literal gap in the muscle, is obvious to the touch.
Right, you can feel the dent.
But the immediate postpartum pelvis is an entirely different physiological environment. It is chaotic, massively swollen, tissue is distorted, and the baseline for what things feel like is completely altered.
So a doctor doing a traditional physical exam, like using their hands to palpate the area, they simply can't feel the difference between a detached muscle and normal postpartum trauma.
Exactly the problem highlighted in the clinical trials. Manual palpation in the delivery room is highly unreliable for this specific avulsion.
The numbers on that were crazy.
Yeah, one study showed that manual exams early on only caught 7 out of 23 avulsions. They missed the vast majority of the torn muscles.
Which is where the high-tech imaging comes in.
Mm-hmm.
The sources specify the use of 3D and 4D transperineal and endovaginal ultrasounds,
Yes.
using ultrasound wands applied externally to the perineum or internally, which gives doctors a 3D topographic map of the muscle structure.
And that topographical mapping is a game changer because it allows us to see through the superficial chaos.
But even then, there's an issue. Yeah.
Yeah, even with advanced ultrasound technology, there is a devious biological mechanism that hides the injury in the first few days. The research calls it hematoma masking.
Okay, I'm asking.
Yeah.
So basically, because the levator ani is relatively avascular, meaning it doesn't have a massive rich blood supply, it doesn't bleed out catastrophically when it tears off the pubic bone.
Right.
But it bleeds just enough to pool right in that empty space.
That is the exact mechanism. In the days immediately following the birth, this fluid collection, the hematoma, sits right in the physical gap where the muscle used to be attached.
Oh.
And when you look at it on an ultrasound, the blood clot physically mimics the acoustic density of the missing muscle.
That is wild.
Yeah, it makes the ultrasound image look incredibly ambiguous. It literally masks the tear.
The body's own localized bleeding hides the structural trauma from the imaging machines.
Exactly. The study showed that when clinicians identified these specific hematomas at the attachment zone right after birth, every single one of them manifested as a full pubococcygeus avulsion 3 months later.
Every single one.
Yes. Once the body's natural processes reabsorbed the blood clot, the missing muscle was starkly, undeniably visible on the ultrasound.
So the 3-month mark is when the curtain finally lifts.
Mm-hmm.
But the sources noted something even more frustrating for diagnostics. 1/3 of the avulsions didn't even have a preceding hematoma.
Right, they were just...
Completely invisible in the immediate aftermath. No blood clot to signal a tear, no palpable gap, nothing.
Which really underscores why relying on physical assessment immediately postpartum is essentially flying blind.
Yeah.
It's an environment where a major life-altering macrotrauma can occur, and neither the clinician nor the patient will have any definitive proof it happened until the structural dust settles months later.
And when that dust does settle, the functional fallout is severe.
Very severe.
We've established that the injury is common with forceps, it's mechanically devastating, and entirely invisible to the naked eye at first. So what happens to you, the listener, the patient, months or years down the line when you're just trying to go about your life?
Well, the consequences significantly alter the biomechanics of daily life. Women with major levator defects have 47% lower pelvic floor muscle strength and 47% lower endurance compared to women without those defects.
Nearly half.
They literally lose nearly half of their functional support.
Imagine losing half the strength in your legs and just being told it's a normal part of getting older or recovering from having a baby.
It's infuriating.
And because the pelvic floor is that dynamic gateway holding everything up, that 47% loss of strength directly connects to some really difficult conditions.
Yes. It is the primary mechanical driver for pelvic organ prolapse, or POP.
Which is?
Well, without that thick muscle band providing tension, normal intra-abdominal pressure, just from coughing, laughing, or lifting a toddler, pushes organs like the bladder, the bowel, or the uterus down from their normal position so they bulge against the vaginal walls.
Oh, man.
The longitudinal data shows that women with a levator avulsion are up to 4 times more likely to experience uterine prolapse.
4 times the risk, purely because the mechanical support was detached.
Yeah.
And the sources also link the avulsion to severe urinary incontinence and serious sexual dysfunction, decreased arousal, less natural lubricant, and reduced satisfaction. It impacts every facet of physical and intimate life.
It does.
But through all of this somewhat bleak data, the researchers actually cracked a code, didn't they?
They did.
They built a predictive risk model to figure out exactly who is hiding this injury.
And the predictive model is one of the most vital clinical takeaways from the recent literature. They discovered that if a woman presents with 3 specific, highly observable risk factors during her delivery, her odds of having a hidden avulsion skyrocket.
Okay, what are the 3 factors?
They are a prolonged active second stage of labor, meaning a long time spent actively pushing,
Okay.
an obstetric anal sphincter injury, or OASIS, which is a severe perineal tear, and a forceps delivery.
So if you have those 3 things happen during your labor, you have a 75% chance of having sustained a levator avulsion.
Exactly. 3 out of 4 women with that specific labor profile will have their pelvic floor muscle torn off the bone.
It is a massive statistical red flag that can be identified just by looking at a standard delivery chart, without even touching an ultrasound wand.
Right. It's all right there on paper.
But amidst the heavy implications of that model, the research also revealed a rather incredible twist regarding how the body responds to this specific trauma.
Yes, the healing data.
Right. A 1-year follow-up study tracked these exact avulsions, and they found that 62% of levator avulsions that were diagnosed at the 3-month mark had actually healed by the 1-year mark.
Right.
Now, most of these were classified as minor avulsions, but still. So what does this all mean? If the human body can magically heal 62% of these tears over a year, do we even need to worry about the tools? Or is the real danger lurking in the ones that don't heal?
If we connect this to the bigger picture, the 62% healing rate is a testament to the biological resilience of the pelvic floor. It's amazing, but we have to understand how it heals.
It's not just returning to normal.
No, the body doesn't magically regenerate the exact same pristine muscle fibers. To bridge the gap, it relies on fiber scar tissue, and the surrounding intact muscle bellies undergo compensatory hypertrophy.
Meaning they bulk up.
Exactly. They bulk up and work overtime to compensate for the torn section. It's essentially a biological patch job.
A patch job that manages to restore enough function to pass the diagnostic threshold.
Precisely. But we absolutely cannot let that 62% recovery rate lull the medical community into a false sense of security.
Because of the 38%?
Exactly, because of the 38%. The 38% of avulsions that do not heal, the persistent major macro traumas, are the ones that lead to severe, irreversible pelvic floor dysfunction.
Right.
The healing rate is a sign of resilience, yes, but that remaining 38% represents a massive preventable health crisis. These are the patients who will suffer from lifelong prolapse, incontinence, and chronic pain.
And largely because a modifiable mechanical risk factor like rigid forceps was introduced into a space already stretched to its absolute biological limit.
Exactly.
Okay, to sum up the journey through your sources today, the levator any muscle is pushed to the very edge of biological possibility during childbirth. Forceps, by taking up crucial physical space and applying immense mechanical traction, dramatically increase the risk of tearing this muscle entirely off the pubic bone, especially when compared to the surface-level mechanics of a vacuum extractor.
And because of the chaotic postpartum environment and that hematoma masking we talked about,
Right.
the structural avulsion is virtually invisible to clinicians in the delivery room. It hides in plain sight, often only revealing itself months or years later through functional weakness, incontinence, or organ prolapse.
But the crucial takeaway is that it no longer has to be a mystery. We now have a validated predictive model.
We do.
We can identify a woman's risk of a hidden pelvic floor tear with 75% accuracy, just based on 3 variables of how her labor progressed:
Well,
forceps, prolonged pushing, and severe tearing.
mm.
We know exactly who is at the highest risk. We know traditional physical exams will completely miss the injury.
Which raises an incredibly important question about the modern standard of care.
It really does.
Yeah.
If we have the 3D topographic ultrasound technology, and we know exactly what the risk factors are, why isn't a routine pelvic ultrasound at the 3-month postpartum mark the universal standard of care for these specific high-risk deliveries?
It's a question we should all be asking.
Are we treating women's long-term physical recovery as an afterthought?
It forces the medical community to ask how standardizing this relatively simple imaging protocol could fundamentally change the future of postpartum care, moving it from a reactive space waiting years for organs to prolapse
Yeah.
to a proactive one where we intervene and support the pelvic floor immediately.
Think back to that X-ray machine we talked about at the beginning.
Right.
If you were in a major car crash, a hospital would never let you walk out the door without checking if your bones were set correctly, just because some surface bruising hid a deeper fracture.
Absolutely not.
Yet in the muddy, chaotic waters of diagnostic postpartum care, the data shows we routinely let women walk away with a major supportive muscle detached from their pelvis, simply because we don't look.
It's
Armed with this data, maybe it's time we finally start looking.